Well, good morning, good morning, good morning, everyone. This is Wednesday, so that means that you're watching the Health, Wellness, and Lifestyle program with Dr. Donna Christensen and Linda Dorman. We're here for another installment here on OurTV.network. We're also broadcasting live on Tempo Television, Apple TV, Amazon Fire Stick, Roku TV, and WSTX Bloomberg Radio out of the U.S. Virgin Islands. In other words, we're where you are, and we're glad that you're with us today. How you doing, Donna?
I'm great. How about yourself?
I've had a little bit of a cold, actually a lot of cold, and it's kind of gotten a little bit, and I'm hoping that it will get to nothing. I know we're in the season of flu. We have now this resurgent COVID to a certain
Mhm.
level,
Mhm.
RSV, I think it's called, or X. I don't even know the
Well,
letter.
the RSV is the respiratory syncytial virus that children are having
Yes.
more than adults. But yeah,
Oh,
we have our share of things going around. But
that's
I'm glad to be home. I got home. I got out of DC yesterday. It was beautiful up until Saturday, and then Sunday, bam, it got cold. So
wow. Oh my goodness.
I'm
Well,
not.
it did get cold. So you're in the sunny, beautiful island of St.
Yes,
Croix, U.S.
yes,
Virgin Islands, where
yes.
we're always going to be jealous of where you are. You look radiant and wonderful. So we have a great program today.
Yes, we
Well,
do.
Sharon Hawks will be our guest today to talk about something we've talked about before, but it's not an old subject, and that's diabetes, because there's so many facets of diabetes with a nutrition and metabolic lens. And how in the world do we get our mind, our hearts, and our thought processes around eradicating and managing this disease for those who can manage them? We'll talk about who who can't, from in terms of lifestyle shifting and changes to reverse diabetes, the impact
Sure.
within particularly communities of color. This is
And
a
that's just one facet, it seems, of what she does. She does a very comprehensive uh, array of nutrition and health and well-being counseling. So we're having an interesting show. So everyone, stay on, tune in.
tune in and get your notes, because here we go.
Yes,
Sharon Hawks, welcome to the program Health, Wellness, and Lifestyle with Dr. Donna Christensen and Linda Dorman as your hosts. We are thrilled that you're with us today, because this is not an old subject. This is not a new subject. It's a timely subject as we head into the holidays, as we head into Thanksgiving, as we just head into the end of the year, and people make all kinds of resolutions to get healthier in the new year. We're trying to get them to stay healthier for the entire part of their lives, for their family and generational health, pass that wealth on. Health is wealth, as we talked about last week on the program. But welcome. How are you this morning?
I'm wonderful. Thank you. So
Good,
happy to be here with you guys.
we're
good, good.
glad you
Great
could join us.
conversation.
Thanks.
Well, we just want to make sure that our listeners and our viewers know who you are. You are the CEO and founder of Nutrition and Education and Diabetes Center. I hope I said that correctly. The Nutrition and Diabetes Education Center, that's located here in the great state of Maryland, which is where we are located. I'm broadcasting from, you're broadcasting from. And that you're a registered dietitian, nutritionist, and diabetes educator, which is very specialized in helping individuals to understand and create treatment plans using nutrition and other means for not only reversing diabetes, the impact, but also addressing how to live successfully with diabetes if you must. Welcome to our program.
Thank you.
Great. Well, let's first talk about, why did you decide to take this on as a career? What was the why for you? So everyone will understand the passion behind what you do.
Well, what's interesting for me is you can tell immediately when I start to talk that I'm Southern born and bred, right? And so
Okay.
down south, I grew up around many people having what was we like to call sugar and not diabetes, right? And trying to get them to understand that both are the same thing. I actually watched many family members suffer with diabetes. I
Mhm.
watched many family members die from the complications of diabetes. I initially set out to be primary care physician, and once I took my first class on nutrition, I was hooked. I realized my goal was not to treat disease, put a Band-Aid on it, but my passion was to prevent it. And so I knew this was a field that could do it. And when I was in the middle of my medical internship, I realized I can actually specialize in diabetes. This is one area in the medical community that a lot of people kind of shy away from because there's so much to know about diabetes and it's constantly changing and evolving. But I wanted to take on the challenge, and I worked very hard to get certified on the national level as a certified diabetes care and education specialist. There's only 19,000 of us in the entire nation that specialize in everything diabetes. And to be very frank, when we look at the African American community, we're only looking at about 4 to 7% of those 19,000 are African Americans. So it's a privilege for me to be able to hold that certification on a level where I can speak to diabetes and help to treat, but more so to prevent.
Yes.
You know, I'm a primary care physician, not in practice right now, but I know how difficult it is in certain circumstances, especially where you're living in a community that's mostly Black and Hispanic, high poverty level and so forth. So as a primary care physician, you can't do it all.
Yeah.
So we need you.
Yeah, absolutely.
Help us. Yeah.
Well, it is a true partnership, Donna. I think you're right. I think the notion that you can go to the doctors and have a cure-all for everything has been dispelled over the many years, not only from a cost and economic perspective, but from a holistic treatment plan, not holistic in terms of non-conventional, meaning just comprehensive. So it is a partnership with our primary care physicians, the patient and the patient's families, if involved, so that they're competent, and individuals who are certified to have that level of expertise and specialty. And I'm glad to hear that. I am a little taken aback, Sharon, that you're only one of 19. And the numbers are so explosive. Is this an industry that we need to start promoting as viable? Because that sounds like I know it took us a little while to get you on the program and you're super busy and we're slipping right into your very busy schedule. So obviously there's a tremendous need out there. How can we get more people involved in this to come certified? That's one of the first questions.
You know, it's interesting about, on one hand, you want to open it up so a lot more people are qualified. On the other hand, the criteria and the requirements to become a specialist requires so much. And so I kind of, go back and forth about, do you want to make it easier or just have the elite to join, right?
We don't want to make it easier. We want.
Yeah. So Dr. Christian, you get what I'm saying, right? So do we dummy it down a little bit for more people? Or I think one of the big issues, honestly, the goal is to get more African American people of color interested in specializing. The other part of it is letting primary care physicians know that we're here, right? A lot don't. I talk a lot in my classes and one-on-one in group education and all the different talks I do around the nation about how important it is for us to work as a team, as you said earlier. I call it the care team. So I let my patients know that I am not the catch-all for their diabetes. The primary care physician, if they're in with endocrinologists, podiatrists, the ophthalmologist, the dentist, everybody work together to keep them well, right? And make sure they understand that it is a team approach.
That's important. And
which they are the primary team member because it's, sometimes I think it's sometimes been hard for people to really take on the responsibility themselves and instead depend on the medication or whatever is being prescribed. But
well, we're in a society where a pill is supposed to be, the miracle drug. We don't do a lot of preventive work on the front end to not get us into these health conditions. And, the metabolic syndrome would indicate if you're obese, there's some other criteria I'd love for you to talk about. That takes us into being pre-diabetic. So this is that time frame where we need to address. I mean, I'm on my spin classes now. I am eating healthier now. I am drinking my requisite number of water because I tag them every day, because I know that if I don't continue in the right way, I will be pre-diabetic, and I may even be pre-diabetic, just, needing to drop some COVID weight and continue to do the right things. First of all, let's talk about what is the metabolic syndrome.
So the metabolic syndrome is actually, oh, I'm sorry, Dr. Christian, did you want to take that, or you want me
No,
to go?
you go right ahead.
Okay, great. So the metabolic syndrome is a group of conditions that come together. So we look at insulin resistance. We'll talk about that. We talk about obesity, but I want to be clear on something about the obesity. And this is what I try to get across to help our professionals. It's not just about being overweight, but where you carry the weight.
Right.
So let's be clear. It's about central obesity, not just about being overweight. Okay. So that's one of the things that get mixed up.
Abdominal.
Yeah, abdominal will be something we call visceral fat. That is so powerful to know. If you talk to anyone who has metabolic syndrome, have prediabetes, have diabetes, their conditions didn't start to get out of hand until that waistline started to expand, right? And there's a reason for that. I can go into that a little bit about that too as well. But please focus in on the central obesity. The other part is the cholesterol issues, right? The high triglyceride levels, and then low HDLs. Now, most of you may know that the HDLs are what we call the good cholesterol. I like to say they're happy, so you want to keep them high, right? Yeah. So those are the ones that should be high, because their ability to remove plaque from the wall and, reduce your risk for heart disease, when they should be high, they're low. Okay, so that's one of the big things that goes on there too as well. That's so important to know. And then of course the insulin resistance.
Mm-hmm. And so I think you made a really good point, and that helps us to kind of centralize it. It's the centralized fat that we need. So our abdominal fat around the waist, that whole band, is what we should be looking at versus just, are you overweight generally? Because there could be some variance in that. And then we need to have our cholesterol numbers checked. We also need to know that almost as much as we know our age and our birth dates, I'm sure, and be able to test on a regular basis, to be able to test at home on a regular basis your cholesterol level, to know where and how food is affecting you, correct? Is that how we understand that to be more? Because we do want to rid our bodies of the unnecessary plaque that builds up, that creates the heart attacks, that creates the cardiovascular issues. And
let me not leave out high blood pressure.
Right.
And that's the other part too. I'm thinking, did I miss some blood pressure? Please let's not leave that one out, because that takes on a whole different connotation when it comes to diabetes.
So these are all together. These are the diseases that make up this concept of the metabolic syndrome. Yeah. So how do we start to?
It really puts you at risk, for heart and cardiovascular disease. So you want to not have that syndrome develop.
Yeah. Because they're all working together. And that's something to know. You're never going to see diabetes stand alone. No one shows up with diabetes. So there are some physicians, and Dr. Christian probably can kind of verify this, is that they don't want to see diabetes as a condition within itself. They think we need to treat it more as a group of diseases together. And that's how we're approaching it now. And we're learning that if you just concentrate on the blood sugar, you're not doing yourself any favors. It really is about concentrating on all those different parts of the metabolic syndrome.
Well, what are a lot of conversation happens and people just use the term diabetes singularly without really identifying the types. And there are two types, correct? There's type 1 and 2. Can you share with us the difference between those two types so that individuals will come to this conversation and can get their notes going? Let's hope that our listeners and viewers are taking their notes.
Well, there's more than two types, but the two major types.
Oh, okay.
Type 1 and type 2. And note, we only call it type 1 and type 2 now. If you go back years ago, we used to call it childhood, or adult onset, right, Dr. Christian? And right. We had all these names for it.
Until children started having type 2 diabetes.
And adults, we found out have type 1, right?
So there's more than two types? Now that's a learning right there.
Well, there's more than two types, but I think the point both of us are trying to make is this: is that type 1 used to be reserved for childhood. We only thought type 1 happens in childhood before age 10 or 12 or so, and that it was unique just to kids. But we now know that you can be a full-fledged adult and develop type 1 diabetes. And on the flip side, type 2 used to be called old onset, adult onset diabetes. And we know now that kids, teenagers, young kids can get type 2 diabetes. So we reserve the term type 1 and type 2 only now, so people understand that it's not related to age really anymore. We're clear on that.
No, so we have evolved and not in a good
And
way.
the type 1 is more insulin dependent.
Mhm.
I mean, type 2 may end up being insulin dependent as well,
Mhm.
but type 1 is an insulin dependent diabetes.
Sure. So type 1s, they will take insulin from the day, pretty much within days or months of being diagnosed to the day they die, unless they get another type of treatment. Because what has happened, the beta cells in the pancreas that produce insulin have been destroyed due to some type of autoimmune response or whatever the case is. They're no longer making insulin. So the only way for insulin role in the body to be completed is they must inject insulin. So it doesn't matter how well they eat, how much they exercise, they can't exercise and eat their way out of insulin. They can make those changes to adjust how much insulin they need, but the idea that they don't need insulin, that is a fallacy.
Wow.
Yeah.
And so is any of the conditions within this hereditary so that you're more predisposed? Or have we evolved now over the last 20, 30 years because the type 1 and type 2 blending between children and adults is no longer as relevant as it was before? Is there something that we should be looking at in our genetics?
Well,
It seems
Did you want to-
as though there's some. It's not always fully expressed, but
Yeah.
I'm out of practice, so you go ahead and give me your more up-to-date experience.
So here's the kind of latest on it, right? Years ago, we used to think type 1 was the most genetic.
Mhm.
The research is bearing out type 2 is more genetic, right? So type 2 is that one we associate with lifestyle a lot.
Exactly.
Right. But let me be clear. As Dr. Christian said, there's a lot of unknown reasons why we develop one over the others. Genetics plays a big part. I would fathom that with type 2, from my experience and from the research, type 2 has a bigger genetic factor. We spend so much time demeaning type 2s and making them feel like the reason they're at the table is simply because of their lifestyle. But the reality is what brought them to the table was genetics. What set them down for the meal was their lifestyle.
Right. Right.
I love that.
With type 2, if it is running sort of in your family, there are things you can do to prevent the onset or lessen the
Correct.
severity of it. And so it's really important to know that.
Yes, because we've talked about getting genetic counseling if you're marrying someone, and particularly if you yourself are sickle cell and someone else is, to get that kind of genetic imprint so that you understand what's happening and if you decide to have children. So it just brought to mind, wow, what else do we need to understand about ourselves genetically so that we can address it more from an academic perspective and work with our primary health physician, work with experts such as yourself to better understand exactly what's happening in our bodies and then develop the treatment plans that are responsive and positive. And so I understand that is some of the things that you do at the center is to develop individualized programs that help individuals address their specific needs. Can you share a little bit more about that?
So diabetes treatment, I think one of the areas we dropped the ball is with a lot of my colleagues is that we approach everyone the same, and that would be a mistake.
Yeah.
Right. In fact, my last patient right before I rushed to get on with you guys was very resistant to change. Right. And so I'm also a life coach. So I've learned to step back and take a look. And I pretty much said to him, we're going to start small and we're going to build our way up. And, but the fact is he showed up.
Yeah.
For me, that's 90% of the battle.
Yes.
So my goal is always to meet people where they are, and particularly in our community. In communities of color, you've got to understand that the way we see the world sometimes will be a little bit different on how we approach things. And so because there's so few of us of color who does this on this national level, it gets really difficult to find someone who can approach you. I've had people who walk in my office and I walk out and I would say, Mr. Johnson, and you see this surprise, like just shocked look on their face, right? And then they smile. This is going to be okay. Right?
Well, it's just reassuring to know that someone like yourself exists, and that works with insurance companies, that work with primary care physicians, that work with community health service providers to make referrals, because sometimes people feel like they don't know where the resources are. They know what they have to do. They may even be willing, and maybe they're willing, but yet they don't know how and where to go and how to access you. That's the critical thing. That's why we do this program, is to create awareness around accessing the various providers and information. And, something that I learned last night that I had never heard, that scared me because I woke up at 3:00 in the morning thinking, oh my goodness, was something called the dawn phenomena. When you, Somogyi, I think, effect. Am I pronouncing it? SOMOGY? Somogy effect. So let's.
I've never heard of it, so I'm curious.
I had to look that up, and as it relates to metabolic syndrome and diabetes. Yes.
Yeah. So Somogy effect and the dawn effect is a phenomenon that happens in the middle of the night. The dawn effect typically is going to occur somewhere around about 5 to 8 a.m., depending on what time you get up. So it's literally right before you rise. Somogy effect tends to happen around that 2 or 3 o'clock in the morning time, right? And what's happening is the blood sugar takes a big dip. And so the body kind of responds, and the body freaks out because the blood sugar is going down. And of course, we don't want to have low blood sugars and stuff. So the body's going to kick in to save itself. And what it does is it pulls glucose from its stores. So I don't know if you know this, but there's something called glycogen stores, where the body stores extra glucose for the case of emergencies. So it doesn't use up all the sugar that's available throughout the day. It saves them for emergencies. And so what's going to happen, it's going to go and pull from those stores. Unfortunately, it's not a very controlled system, in the sense that it's not going to send it up just where it's back into normal. It's going to overproduce. And guess what's going to happen to the blood sugar? It's going to pop up and go through the roof, right? So what causes the dawn effect and Somogy effect, that's a whole nother lecture within itself. But what I will tell you is it's predicated mostly on hormonal shifts. Right. And so when we have something we call counter-regulatory hormones, everything from epinephrine to cortisol, there's a list of them. And they're most active right before you get up in the morning. So what could cause them to overreact? And let me take a step back. One of the counter-regulatory hormones that plays the biggest role in this dawn effect, they all work together, is something called glucagon. So simply understand what glucagon is. To make it very plain, it is the opposing hormone to insulin. So when insulin comes on the scene, what does it cause the blood sugar to do?
It drop.
When glucagon comes on the scene, it causes the body to release the glycogen stores, and up goes the blood sugar. So I have patients all the time go out, I don't understand what you're going to do to help me, because I have tried to get my blood sugar down. I stopped eating and it's still high. Explain that. I said, oh, sure, I'll try. Right. So they assume because they don't eat, the blood sugar is going to go down. That's not always the case, because the body has a backup system in that glucagon. Right. And so the hormones are what's causing this. What can prevent the dawn effect, Somogy effect? It's an individual thing. I have to sit down with the patient and try to figure out what's causing it. Stress plays a role. If you don't get enough sleep, I guarantee you're going to have a high blood sugar in the morning.
And you mentioned cortisol. So that's the stress.
Exactly. You know what cortisol does. So that's that hormone that's going to cause the body to send that blood sugar up. It's going to encourage the body to uptake fat. And guess where it wants to put that fat when cortisol levels are high?
Probably in the abdominal area.
So the
Yeah,
very
we're
absolutely.
gonna have to take a break in a few seconds.
Oh my goodness, we're over for our commercial break. Oh, I just got so focused. We're going to come right back and pick that part of the conversation up. So we thank you very much on the Health, Wellness, and Lifestyle program, Belinda Dorman and Dr. Donna Christensen. We'll be right back with Sharon Hawks.
I'm Charles Meriday, and I'm in the restaurant business. In my 20 years as a chef and restaurant owner, I've been able to work and eat in some of the great kitchens around the globe. There's a whole side of the restaurant that most people will never get to see. So now, I want to take you to the back of the house, into kitchens of some of the best chefs in the world. Along the way, I'll share some of my own tips and recipes so you can cook like a pro too. So join me in the back of the house for a whole new perspective on cooking and food. Order in. Roger. Serve it, please.
I'm glad that you came. Please.
Welcome back. Oh my goodness, we're having a great conversation with Sharon Hawks. And the conversation has been around the metabolic syndrome and diabetes. And we're just so delighted that she's joining us today because we're already learning something. A, that we need to focus on our centralized fat. B, we need to get some sleep because if we don't, we're going to raise our cortisol, we're going to deal with sugar. I mean, there's just a whole host of things that the metabolic syndrome is a collection of issues. It's not just one issue, it is a collection of issues, and we need to have an individual care plan working with someone just like Sharon Hawks that knows and educates and is one of the few 19,000 out of our entire United States who is certified in diabetes education. It is critical that we all run to you, if nothing else, to get information, even if we believe that we're healthy. You know, that could be a misnomer. We could be pre-diabetic. So welcome back to the program.
And that's true because a lot of times by the time a person realizes that they are diabetic, they've been pre-diabetic or diabetic without having any noticeable symptoms for a while, but all of the types of complications that can develop can have started already. So the control of your diabetes is so important. I just came back from my American Kidney Fund board meeting. You remember we had the CEO, LeVar on with us the other day, but diabetes, as well as hypertension, but diabetes is a major factor in creating kidney disease and having folks end up on dialysis. And it can be prevented or at least delayed.
Well, tell us how those impacts, because diabetes, Sharon, we in Prince George's County, we did a community health assessment need of all the hospitals and looking at collectively what are the cases and things that are coming in, what are the comorbidities, and diabetes was at the top, and it was shocking on one level, but probably could be expected with another with the type of food sourcing that we do have, the access issue to healthcare, and the unawareness of something as critical as the dawn effect, as what do we do about our sleeping? You know, just some very simple shifts here and there. What are all the other things that, you know, the pancreas, the liver, the brain, you know, how does this impact other parts of our body? We know that this, you know, obviously the cardiovascular system we talked about, but, you know, to your point, Dr. Christensen, what's the how?
And you might also talk about, you know, if you know that you may have a predisposition or there are a lot of diabetics in your family, what are the types of eating? How should you plan your diet to either prevent or delay onset or mitigate the onset?
Yeah, that nutritional piece.
Yeah, and it's such a big part of all this, right? Because that's what tends to plague most people when it comes to diabetes education and training. I simply ask the question whenever I'm doing a group. I do a diabetes class every week that has about 20 or 30 people in it, right? And when I'm talking to this group, the question I always ask first, what is the main thing you want to get out of this education? 90% simply say, what can I eat? You know, all the other stuff is nice to know about what causes diabetes, what complications. What they really want to know is, how do I manage this thing day to day? Right. Mm-hmm. And so what gets tricky there is finding people who can help them to get there. And as an educator, one of the things we approach, I approach it from a way of concentrating on the areas that we know is going to have the greatest impact on the blood sugar. And as we know, it's carbs, right?
Yes.
But here's the thing about carbs that shocks people. I start off by saying this, and I make my case by the time I'm done, is that carbs are not the enemy.
Exactly.
Right? They are not the enemy.
You mean I can have my French fries?
It's the amount that you consume, the timing of it, right? Mm-hmm. So I can teach them, you know, I always used to joke, you can be a junk food junkie and I can teach you how to control your blood sugar. if you understand how the body works in processing carbs and energy. And so I go all in to a level, you don't know how many times when it's a 3-part class that I teach, that when people finish the class, I've had people who are just floored by the information that they've gained. Dr. Christian probably can speak to this, but I've went over this over and over in my mind about why the information I'm giving out seems to be new knowledge to almost every person who walks in to see me, whether they've had diabetes for 2 months or 20 years, right? That they haven't received this information. We go back to there's not enough of us around. But the other part is in physicians' defense, they don't have a whole lot of time. They paid me in half an hour increments to see patients.
That's right.
So correct me if I'm wrong, Dr. Christian, they pay you in 10 or 15-minute increments. And
yeah, well, I was lucky. I didn't have to deal with all of that.
Oh, so you didn't have to deal with all that.
20 odd years ago. No,
yeah,
yeah,
you just got
you are
the
correct.
time you needed.
That is a very true statement. And I was so shocked to find that out when in the middle of a conversation, my doctor looked down and said, well, we're going to have to reschedule you for another appointment. I'm thinking, we haven't done what I remember doing with the doctor about 10 years ago. I mean, this was the same, doctor, another doctor bought the practice and then went into the corporate practice. Someone bought their practice, a hospital system, and that shut it down. 30 minutes, and we're talking 30 minutes, a fast 30 minutes. It was the scariest experience.
Sometimes you don't get 30 minutes. You might get 30 minutes.
The 30 minutes total.
The whole night.
And out.
Yeah. So if we only have that amount of time, how do we learn about things like, recently I was doing a study around whether I should give my children like cow's milk as an example, or not give them cow's milk. What happens in the body as it relates to diabetes, as they grow, just trying to find all those nuances to make a healthier household, a healthier plate.
Yeah. Let me say this something interesting. And I, Dr. Christian, you can chime in on this if you want to. I was doing a talk, and a physician friend of mine, I said, with all due respect, I'm told that the average physician has 1 month of nutritional training in medical school.
Oh, true. And I'm surprised that you were in medical school and your nutrition course is what made a difference in the direction that you took. Because my nutrition course was boring.
Exactly.
Absolutely nothing.
And then he laughed, right? He said, may I interject? We were in the middle of a lecture. I said, absolutely. He said, with all due respect, when I went through medical school, it was an elective.
Oh my goodness. Can you imagine that
so you go into your physician, exactly. You go into your physician to get information that they're not privy to, right? So I make the point. You wouldn't go to your primary care physician if you had a problem with your eyes.
Right.
So why are you expecting them to understand nutrition and diabetes to the level that you need? Go to the specialist. I have patients who come in and, as a certified diabetes care and education specialist, we must know every aspect of diabetes. So I can talk about insulin, I can talk about oral medication, I can talk about food, I can talk about complications. But I understand that when you get into certain aspects, you need the specialist. Patient came in one time, the first thing he did was took off his shoes and he held his foot up, his big D groove on the bottom of his foot like this, and stuff. And he goes, you think the diabetes caused that?
Oh my gosh.
Yes, because you're not healing as you should. And if the blood sugar is too high, you won't heal. He says, what do I need to do to fix this? I said, I have no idea, but I'm going to refer you over to my podiatrist friend across the hall.
Right. Yes, you got to
stay in your lane. That's what I tell people. And that's why it gets so difficult that physicians, a lot of times now, they're getting kickbacks in order to keep a patient out of the hospital.
Right. It's very expensive.
So they're smart. They send them to the expert and we do our job and they get the money for the kickback by keeping them out of the hospital.
Well, also in Maryland, as an example, when I worked in my health care system, the state of Maryland is very peculiar. They are putting the onus back on the hospital that said, if your patient walks in 31 days and under 30 days, you're not going to be reimbursed.
Yeah, that's true.
And so it behooves them to say, let us find Sharon Hawks for every treatment because we're going to refer out into our community network. And that's where the benefit of that community health programming, that strategy around developing expertise and making sure that you have all the resources you need to do the type of work that you're doing in educating and providing treatment to these patients whom, if they walk back into the hospital because they have some issue that relates to what they've experienced that brought them there the first place, for sure, that's going to be a problem.
Sure.
So it comes down to dollars and cents. It makes more sense to get the information versus trying to spend more dollars because the dollars are not there.
Yeah. And I got to say they're doing better. They have new case manager systems. They got a lot of different programs they have for patients. That I had a patient came in yesterday who had on a machine called the CGM, continuous glucose monitor. That's a game changer. I was talking to Terry about that, and she's very interested about how that works. And for that patient, what gets difficult, it depends on the insurance company to say who's going to authorize it. We've got to do better on being able to get the treatments, the information, the equipment that patients need to have the best outcomes. And that's an area that this nation is falling short in.
That is a really important. I don't want us to gloss over that. That was actually one of our questions regarding this particular device. Can you, because it is a game changer. So because we need to go into advocacy, we need to push.
It makes a world of a difference.
A world of difference.
I even had doctors in one conference, a panel, a doctor who was a diabetic, and when they were able to use some kind of remote monitoring, I don't know exactly what he was using, he said it made such a world of a difference in his life.
And I'm just learning about this, the CGM.
CGM, continuous glucose monitor. So there's several companies that make them. Let me say CGM's been around for decades. The only reason why they're getting such talk now is because recently, over the last 4 or 5 years, they have a lot of insurance companies have approved for type 2s to have CGMs. They were strictly reserved for type 1s who was using the insulin pumps. So what the CGM, continuous glucose monitor, does is a device, and you may have seen it on someone's arm or it's on their stomach area. There's several places on their body they can put it, but most people are familiar now with the one that type 2s use. I won't call the company name just for conflict, but it's a little disc that goes on the backside of the arm that, just in the kind of fatty part of the backside of the arm. And it sends information to a receiver. And now you can use your smartphone and everything's on there. And it can give you your blood sugar reading 24/7. You can take your blood sugar 1,000 times a day. All you got to do is this.
Oh my goodness. I think yesterday in my yoga class, I saw someone with a little disc right on their back.
That's what it is.
And I just thought that's a very interesting tattoo. And then I just was so glazed about it because they were sitting in front of me that I have never seen that. And I bet you that's exactly what it is, because they had two, one in the back of their neck and one on the arm.
So typically you only put it in one place. One in the back of the neck may have been something else.
Oh, okay.
But it's just a little round disc that goes into place. It snaps into place. The one that type 2s use, the most popular one, you keep on for 2 weeks. And so you need 2 discs a month. And then you change it out in 2 weeks and put another one on. And so what's neat about the CGM, not only do you get your blood sugar 24/7, let me tell you the pros and cons, right?
Yes.
Expensive. Because all insurance don't cover like they should. I have to get off my soapbox, but I have to say this. I'm very appalled by the fact that the amount they charge for the copay. So it becomes a thing of the haves and have-nots, who gets to use it and who don't, right? Because the sensors can be anywhere from $25 to $50 a piece.
Wow.
Well, we do like to talk policy, so it's something we need to follow up on.
I don't know if y'all talk policy or not, but
we do a lot of talk of policy.
That bothers me immensely.
Yes,
because I have patients living in Prince George's County, one of the richest Black counties in the nation. We have a lot of people have a whole lot of money and can afford to do it, but we do have pockets in this community who are underserved, and we need to be able to address them. And a lot of times they're the ones who need this type of technology more than others, and they don't have access to it. The second issue is the learning curve, right? It's a beautiful thing. It gives you the numbers 24/7 forever, But what do you do with the numbers if you don't understand it, if you haven't been educated to understand what the numbers mean? Most physicians haven't been trained on how to use it or how to interpret the information. So patients usually walk in with me with bag in hand. I was like, when did you get that? About a month ago. I couldn't get in to see you for a month. Well, you have instructions, you got on YouTube. Nope. I decided to wait till I get in with you. And typically at physician's office, there's no one there who can show them how to install it initially. So that's one of the issues too as well. And the learning curve about not only getting the numbers and knowing what to do with it, that machine can do so much. It does something beautiful called time and range. So here's what we know as educators. If we can keep that blood sugar within normal range about 80% of the time, they're going to get a normal A1C. Mm-hmm. So that little machine can kind of tell them the future of what things are going to look like, right? Mm-hmm. But the beautiful thing I love about it, it can identify those highs and lows. Where we were talking about the Somogyi effect and the Dawn effect. I had a patient who, actually a friend of mine, had diabetes quite a few years. And I won't go into, she has one of these unique types of diabetes. That's a whole nother conversation. But she was waking up in the morning with extremely high blood sugar. So I immediately knew it was probably the Dawn effect or Somogyi effect, because I had her to check her blood sugar before she went to bed. Mm-hmm. And lo and behold, the blood sugar was normal before bed. Mm-hmm. And so what would cause it to rise? So I knew it was one of the two, didn't know which one. And it's important to know which one, because we're going to treat it a little bit different than how we approach it. So I recommend she get the CGM. And we went through all the different things. I had to write a note to the insurance company, the whole thing. She found lady to get the CGM, and immediately we saw that it was Somogyi. Mm-hmm. And so I knew immediately what to do to conquer that. The doctors had no idea. They wanted to raise the medication. I said, stop, don't raise the medication. This could make it worse, right? But the blood sugar is high in the morning, but there's something happened hormonally in the middle of the night that's causing it. And because they didn't understand the process, they wanted to raise the medication. And so once we saw the Somogyi effect, I was able to make the adjustments without having to raise the medication. And in fact, all we had to do was make some changes to her diet, actually, and her stress level, and we were able to get it under control.
Oh, that is outstanding. Well, it's important. So there is hope. And I think that's what we want to make sure that our listeners and our viewers hear. So how do we get those listeners and viewers smart in trying to find you and your colleagues in the field? What kind of questions should they be asking?
So one of the things you can do is go out to the Association of Diabetes Care and Education Specialists. It's a website. Just put in diabetes specialist, and that website should come up. Association of Diabetes Care and Education Specialists. We used to be called Certified Diabetes Educators. Dr. Christian may remember that was our previous title, but they changed it a couple of years ago because I think a lot of times health professionals assume all we did was education, not understanding that we're versing everything diabetes.
Yes.
Right? So they changed the name. So they can tell you where you have specialists in your area. Again, because there's so few of us, here's another issue that comes up with it. There's so many things to answer your question about why we're not getting the care. A lot of the specialists are attached to hospital systems. And what makes it difficult, you know where I'm going with this. So it becomes a very streamlined kind of way of how education has to be done and different things. With me being in private practice, I have a freedom to be able to set up the program how I feel the patients need. And what may surprise you, with only 19,000 of us in the nation, right now I stand with 4 certified diabetes care and education specialists in my practice.
Oh my goodness gracious!
You say, how in the world?
Yeah.
Well,
so why don't we give everyone, before we run out of time, how would they specifically get in touch with you? Do you hold virtual?
Virtual, yes. My classes right now are virtual. We were hoping to do a kind of hybrid, but numbers going back up and all kind of stuff. So we're kind of keeping it virtual, which I'm surprised is working very, very well. It took me a
Good.
minute to kind of get used to this, but I'm quite versed in this now. Over the years, we all were forced to kind of rise to the occasion,
Right.
right? And so it's going very well virtually. I do have access to in-house for patients too as well. I do have senior patients who don't like to be online, and patients with disabilities and different things. So I do have patients that come in the office still. Most
Well,
of my other educators are online. They come in sometimes for events we may have.
so if others are listening across the country and just feel inclined to reach out to you, how can they reach out to you? What is your website? What is your
Oh,
contact information?
good. So my website is nutrition-diabetes.com.
Okay.
Nutrition dash versus underscore, correct? It's a dash.
Dash. Yeah. So my email is nutrition_diabetes at
Okay, all right.
msn.com.
So
Yeah.
nutrition
So
dash.
and if you Google my name, all my information will come up too as
It
well.
does. It
Yeah.
does.
Don't we love Google because that gets us the straight
Yeah.
where we need to go.
I
Oh
don't
my
know why people ask me questions, that they could just Google.
Yeah,
No.
just Google the name. If you've been
I
involved
did.
enough. So with that, I'm involved also in a lot of other great organizations. My church is one of the mega black churches in the nation, and I'm over their health ministry. I'm the health commissioner, so we're able to do great things. We're actually doing a diabetes symposium this weekend.
Oh.
This being Diabetes Month, by the way.
It is. It
And
is.
we'll be doing a diabetes symposium this weekend to answer those questions that people have. So I'm bringing in some friends who are experts, ophthalmologists, podiatrists. I have someone who's going to be doing exercise, which is so important with diabetes and prevention. So we're going to be answering those questions, those tough questions that people have that when it comes to diabetes care.
And what is the biggest thing that we can leave anyone with at this point in time? We want people to know that it can be reversed. You have to work with the experts and you have to become competent in your knowledge. It's critical, no matter even where it sounds like it doesn't matter where you live, per se, in terms of food desert, because that's always been kind of the extreme. It doesn't matter even about access, because you yourself can make the choices necessary to live a healthier lifestyle and all that it requires.
But makes it difficult, though. I mean, sometimes it's really hard. Some people can't get the exercise in the neighborhoods that they live. They can't get the healthy foods. But, like some clinics are, like some of the major healthcare systems now do prescriptions for food.
Yeah.
And so that they can take that prescription and get some healthier food somewhere. Hopefully there's a place nearby that they can get to. So we're really beginning to understand those social and economic determinants that trying to figure out how we can overcome them.
Yeah. But if I had to have a last word on how to take care of yourself, it comes down very simply. I'm in the middle of writing something right now. I try not to talk about it because it's slowing me down from completing it. But I talk about what are the things we need to do to stay healthy. We make it so difficult. And I think if we just key in on a few things, I told you when my patients come in, I set goals. As a coach, when I set the goals with them, I allow the patients to pick their goals, not me.
Mm-hmm.
I only identify where their strengths and weaknesses lie. And then we work together, as Dr. Christensen said earlier, as a team. That they are their biggest advocate, not me, right? But they got to want this. So when I sit down with them, I meet them where they are. And some of the things I'm going to talk about is things we don't discuss. How important stress levels are, sleep, right? But that big one is how you eat. That timing of your carbs and your food, spreading it out throughout the day, cutting down on portions. We just eat way too much.
Absolutely.
We just eat way too much. I tell people, the truth is, if you just cut your portions in half, I wouldn't even have to go into the carbs and none of that protein and fat. Just cut it. We eat way too much. So if we cut down on the portions, and the biggest one, I was doing a lecture once, and the gentleman said to me simply, what's most important, exercise or diet? And the point I made to him, they're both important. But get this, the nutrition expert said if I had to fall on the sword on one side, it would be exercise. Your body is made to move.
Made to
You
move.
have got to move. Exercise covers up a multitude of sins.
Well,
It brings up some of the overeating that you're doing.
That is
we're
correct.
gonna need a part two. We're gonna need a part two because we're about to be we're already over, but we're gonna need a part
Wow.
two, Sharon.
That
I
went
know
by
it went by
quickly.
fast. So what we're gonna do is bring you back on the show and talk about those kinds of practical tools to get going, to eat well, to get move,
Yeah.
all that we need to do. So we're sorry that we've run out of time because it's been so good. And we're gonna, for those in the DMV, please tune in to NCBW to the continual conversation tonight. Go to ncbwpgc.network to get the information to register. And we look forward to continuing this day in Diabetes Month. Thank you so much, Sharon Hawks, for being with us.
Thank you so much.
Thank you. Thank you. We
Great
look forward to
Wednesday.
having you back again.
Pleasure.
Yes, we look forward to that. Thanks, Tony.